Okay. Did
Currently
Thomas join?
downloading
Thomas,
it.
can you hear me? Thomas or Damon? Martin, you are here. Martin, can you hear me?
We need to unmute him because
Okay.
the meeting hasn't started.
Okay.
Yeah, I'm just downloading the PPT.
Yeah, can you unmute him?
So I'm downloading the PPT first.
Okay. Okay.
So, okay, it's allowed for Martin.
Yes,
It
now
is allowed.
Yes,
Yeah.
can you hear me now?
Yes.
Yes.
I can
Yeah,
hear you
I'm
now.
Martin. How are you?
Hi,
Yeah.
hi, Anthony. Thanks for
How's
unmuting
it
me.
going?
Good.
Now you are unmuted, right?
Yes.
Is Thomas here? Thomas.
Let me know.
Damon?
Let me know
No?
if you can see my screen, Anthony.
I can see it's working.
Okay, perfect.
Okay, I'm going to. Can you unmute Damien, please?
Okay.
Damien from.
Yeah, he has access now.
No, yeah, he just joined. Let me.
Yes, I can. Hello, Anthony. Hi, everyone.
Hi, Damien. How are you?
I'm
Thanks
fine,
for
and you?
joining.
You're welcome.
Very good.
Thanks for organizing. Over.
Isaac, can you unmute Ines?
Yes, just a bit.
Yeah.
Ines is unmuted.
Hi, can you hear me?
Yes, we can,
Yes.
Ines.
Hi, Ines. Welcome.
Hi guys. Thank you.
Thanks. We'll be starting shortly. Damien, is Thomas joining or it will be you only?
Thomas and Mokhtar is already online with us. Thomas is supposed to join, and he need to be unmuted actually because he will present.
Okay.
Over.
Yeah. Is he? I cannot see him.
I unmute Mukhtar.
Oh yeah, of course. Mukhtar.
And Zaba.
Yeah.
Thomas.
Yes, Thomas.
Oh, okay. Hi, good morning, everyone.
Hi, Mukhtar.
Okay.
Welcome.
Also,
Thank you very much.
also Thomas is available as well.
Yeah.
Yes, please.
Okay, thank you.
Can you hear me? Okay, I think we can start. So, hello everyone. Thank you for joining. My name is Antana from the Global Nutrition Cluster. My role is Nutrition Information System. I hope I see most of familiar names, so I hope you know me. And today's webinar, as you know, is going to be 2+ hours, a very extensive content, a very rich content. I'm happy also and having a pleasure of a number of colleagues from IPC, GSU, from Reach Impact, and of course our team. And you have already started introducing yourself by writing your name, where you come from, and your role, your organization. Please continue to do so. Let me start by introducing my presenters. Let me start from Azimi, Dr. Saeed Azimi from Afghanistan. Azimi, please introduce yourself. Is he here unmuted? Isaac, can you unmute him? In the meantime, you can start with Damien, please, and Thomas from IPC GSU.
Good morning, good afternoon, colleagues. I'm Damien Pereira-Ngono. I'm working for the GSU as a nutrition specialist, and I have been recently appointed to work especially on Asia and Near East. So if you are based in those parts, we will interact soon. Over.
Excellent, thank you. Thomas, please.
Hello. Hi, can you hear me?
Hello.
Thomas, can you hear us?
Yes, can you?
Yes, please. Please introduce yourself.
Okay, great. Hi, everyone. My name is Th Zaba. I'm IPC nutrition specialist with the IPC Global Support Unit. And yeah, be interacting here in this session. Happy to be here with you. Thank you.
Thank you so much. Azimi?
Hi, Antana. Good morning, good afternoon, colleagues. It's Saeed Azimi, Information Management Specialist from UNICEF Afghanistan Country Office. I'm very glad to be with you. Thank you so much.
Thank you so much. We have also Martin.
Hello, everyone. My name is Martin Jeroke. I'm working with Impact Reach Initiatives at the headquarters, and I'll also be presenting on alternative sources of an assessment methodologies. Happy to be here. Thank you.
Thank you so much. And once again, I welcome everyone for joining. And before we proceed, I would like to also invite and introduce Ines, our Chief of Global Cluster Coordination Unit of the UNICEF Office of Emergency Operations. So I would like her to start the meeting by formally opening it. And please, Ines, the floor is yours.
Thank you, Antony, and thanks, colleagues. I feel I'm back home, right? I used to be part of the GNC, so I'm glad to see a lot of new names that I know. So I'm here on behalf of 𝗶𝗲𝗍𝗍 because he couldn't join today. He asked me to be part of the opening of this important webinar. So good morning, good afternoon to all the participants that are joining us today. It's a great pleasure to welcome you to this important webinar on the alternative data collection and analysis methods. As you know, humanitarian challenges grow and are more and more complex. So we do have conflict zones, climate-related crises, and timely and reliable nutrition data becomes not just a technical necessity, but is a life-saving tool. However, given the funding cuts, the current situation, what is happening this year, I think the availability of the Global Nutrition Cluster to conduct timely and robust needs assessments and analysis has been quite impacted. In response, the Global Nutrition Cluster has been working closely with the IPC Acute Malnutrition, the Nutrition Information System Global Technical Working Group, REACH, Impact, UNICEF, and WFP to develop innovative and reliable approaches for collecting and analyzing nutrition data in challenging contexts. As part of this joint effort, a set of adaptation guidelines has been published recently to support data collection and analysis regarding also the current constraints and similar future emergencies. This webinar will introduce the newly published guidance and share practical examples of how these approaches are being applied in the field. I encourage everyone to engage actively, share insights openly, and reflect deeply on how these methods can be adapted and applied within your country context. As always, I think the Global Nutrition Cluster teams remains available to provide you with the technical support you need. And finally, I would like to sincerely thank all the presenters for the collaboration and contributions to today's sessions. Thank you, and I look forward to the discussion ahead. Over to you, Anthony.
Thank you so much, Ines. Thank you for your important remark. Okay, so we proceed to the next slides. Isaac, please show me the next slide. Isaac, also please introduce yourself. I haven't introduced you as a presenter, but you are part of our team and you made this session possible. Please introduce yourself.
Hello, hi everyone. I'm called Isaac Macha. I'm part of the rapid response team for the Global Nutrition Cluster, my role being information management. Over to you, Anthony. We have a hand raised by Mokhtar.
Go ahead, Mokhtar, please.
Okay, thank you very much, Anthony, and thank you so much, Ines, for this opening session. So my name is Mokhtar Moussa. I'm working with the Global Support Unit as nutrition specialist. So I just want to introduce our colleague from UNICEF Niger, who will present the Niger experience, 𝗿𝗲𝗋𝗀 𝗀𝗀𝗋𝗀𝗀𝗋𝗀𝗋, who will be also part of the facilitation team. So welcome also, Guy. Over to you.
Thanks for joining. Thanks a lot. Okay, so today we will be covering a lot of topics. We start with, obviously, with overview. I will be giving you a general overview of why we are having this webinar on this particular topic. And we have a number of presenters as we have introduced from IPC, Acute Malnutrition Analysis Global Support Unit. They will be presenting about the methodological aspect of things. We do have also presentation from the countries, from Afghanistan on the implementation of Sentinel surveillance system in Afghanistan. And we have also Niger experience on mass MUAC screening. And we have a pilot on inclusion of MUAC in the MSNA, multi-sectoral need analysis. So all these colleagues will be presenting, and it's going to be relatively more in-depth session, each one of them. And finally, we will briefly talk about the 2025 assessment plan. We will show you the assessment planning template so that, as usual, by the end of first quarter, beginning of second quarter, every year we compile assessment plan. This year we understand that resource constraint is the main challenge. And given these resource constraints, you will have to include as many assessment methods as possible. Usually we include standard methods like SMART survey or rapid SMART, as you will be introduced in the next presentations. Now, we have a guidance which will allow you to apply all available methods of data collection. So with that, I will proceed to the overview section. Please, if you have any question, post your question as a chat box. Our team will attend to your question and address your question accordingly. And if we have to also speak, if you want to speak and ask a question or comment, please raise your hand, and that way we will unmute you and you can ask a question. Okay, so before we start, I would like to ask all of you what challenges you have experienced when it comes to need assessment analysis in the past, or what do you expect to experience in 2025? Do the things that we listed on the screen apply to your condition, to your context, like availability of funding, cost of conducting assessments, the technical expertise limitation, logistical complexity, or a complex or rigid methodologies, lack of guidance on using existing secondary data, little or no guidance on qualitative methods? Are there lengthy processes in accessing reliable and timely data? Do these challenges apply to your context, and do you also expect to experience this in 2025? Please, you could say yes, or you could also mention any of the challenges you are experiencing in need assessment and analysis in your respective countries. So please, you can write as a chat box. Tracy says yes. Additionally, inability to conduct smart surveys, that's Regina. Barbara says, okay, she's introducing herself. And Dalemo is saying, yes, we do share these challenges, we do experience them. I hope so many of you are familiar with these challenges. They are not new, but they could be, you will be experiencing more of these challenges given the current significant funding shortfall. But I'm sure everyone agrees that these are one of the commonest, if not all, among the common challenges we face in need assessment and analysis. Next slide, please. Yeah, so the Global Nutrition Cluster and its partners, that is the Global Nutrition Information System, the IPC, AMN team, and also our partners recognize that, yes, there are significant challenges in need assessment and analysis, and it becomes a very challenging, even more challenging this time around, given a significant reduction in funding. And some of the most common challenges we are experiencing, and the reason also that necessitates the need for having alternative data collection methods include high cost. As you know, traditional methods of assessment usually like the smart survey or household survey, they are quite expensive. And also they require specialized expertise and experience. And in terms of applying them in the field, there is operational complexity. They require a number of teams, supervision teams, data collection teams, an expert in data analysis, and all sorts of team members who are experts in assessment and data analysis. It requires a lot of resources and human capacity. And the methodologies are also very rigid, and we have to make sure that the quality standard meet the data analysis and data collection standards meet those established standards. And there is also limited use of existing data. You cannot usually use secondary data for household surveys, and so you rely only on primary data collection, and there is a limited room for using your existing data. And there is also little room for expert judgment. As you all know, your context, in your context, you know it, the local people know it, the local experts know it. However, there is no room for applying that context knowledge towards the analysis exercise. So basically, the methodology limits the application of context knowledge in the assessment and then analysis exercise. And that means the analysis is primarily on quantitative methods. And as we know, only quantitative methods have their own limitations. They need to be combined with qualitative and semi-quantitative methods. So overall, the impact is that we cannot have the right data at the right time for making a sound decision in humanitarian or development planning exercise. So because of this, it is important that we introduce various alternative methods that will address all these challenges. Next slide, please. Isaac. So why do we use alternative data source or alternative methods for collecting data and analyzing data in various methods? One, the issue of cost. These alternative tend to be lower in cost, and they are also low capacity friendly. You can implement them in a context where you do not have all the necessary experts. And in terms of operational simplicity, they are much more simpler than the standard traditional household survey methods. And methodology-wise, they are flexible, and then in conventional sources, they can be data already collected from other sectors, or it could be data coming from your service delivery. So there is a flexibility in that sense. And it allows also the better use of existing data. We do collect data through our service delivery mechanisms, through our routine monitoring, but that data is rarely used for need assessment and analysis. So this allows better use of existing data. And it allows also incorporating expert judgment. As I mentioned earlier, in the standard household surveys, in this kind of methodologies, it is primarily based on the data collected from the households. There is little room for incorporating expert judgment and expert knowledge in the analysis process. And also in alternative data source, one important aspect is the use of proxy and context-specific indicators. So that these alternative data sources usually allow introducing context-specific and proxy indicators. And while they are flexible in so many respects, it's also possible to embed quality assurance mechanism. So overall, what we would expect from the alternative data sources is a lot of flexibility, a lot of operational simplicity, plus embedded quality assurance that ultimately give us a dependable quality data for decision making. So we have to note that alternative methods does not mean poor quality or compromised results. They should be applied carefully, and we should be making use of all the embedded quality assurance mechanisms, so that although these methods are flexible, they need to be also applied carefully by ensuring that they meet the required data quality standard. Next slide. Okay, before we proceed to introducing the specific types of alternative data methods, I would like to ask all of you to list what alternative data collection and need analysis methods you know in your context from your experience. What methods do you know? You could mention secondary data collection. You could mention any other method that you know. So would you please take a minute or less to write what alternative data collection and need analysis methods you know, and which of these methods you have applied in your country context. So please write at the chat box. What alternative data collection and need assessment methods do you know, and which ones you have applied? Again, to remind you, when we say alternative data sources, it means methods which are different from the usual gold standard methods, like the likes of Smart Survey or Rapid Smart. Any other method that you know that you have been applying in your context. I see community surveillance, Regina mentioned at the chat box. Nekar mentioned desk review, secondary data collection method. Meherat mentioned the MIRA assessment, a rapid nutrition assessment. SENSE was mentioned by a colleague from Addis Ababa. SENSE is more or less similar to Smart Survey. So we do not necessarily consider SENSE as alternative methodology based on the definition that I just mentioned earlier. 𝗶𝗲 HiHiCe 𝗃𝗀𝗁𝗃. Alexa, welcome, Alexa. I have seen mass MUAC screenings applied in various settings. Yes, that is true. And today also we'll be having a presentation from Niger on that particular topic. Telephone service, that's Nagla. Routine immunization monitoring at health facilities, yes. Gali, of course, she will be sharing the experience later, mentioned about national MUAC screening coupled with vitamin A supplementation and campaign and IPC analysis. Anything else so far? Very good answers, very good experiences, a very good knowledge of these methods. Need analysis in Venezuela using key informant interviews. Nutrition vulnerability analysis. Yes, it is more of analysis methodology, but it's a very important one. It has been very useful in very important contexts, especially the last 1-2 years. And interviews. Okay, so you mentioned quite a number of methods which have already been applied at different countries. Of course, here and there we do have methodologies, guidances on this one, but we do not necessarily have a well-structured methodology on those various alternative data collection methods. So today what we'll be doing, we'll be taking you through each one of them, if not all, but most of them, and the most commonly applied, and you will have opportunity to learn how to apply these methods in your context. Next slide. One thing I would like to mention is there is also a set of guidelines which are produced to support the application of the adaptation measures in need assessment and analysis. I would like specifically to mention the adaptation guideline, which is recently been developed by the Global Nutrition Information System Working Group. Today, unfortunately, we couldn't launch it because the lead, Hassan, who is the chair and co-chair of NIS-GTWG, he couldn't join us, but the guideline will be released in a couple of days' time. This is an adaptation guideline which outlines the various recommendations in terms of applying various alternative methodologies in the contexts where we have significant resource constraint, and of course it can apply to contexts where there is a limited humanitarian access. So we do have a very good guideline, I do believe, which will help you to implement this assessment and need analysis adaptation measures. And in addition to that, as you will be seeing in the next hour and so, there will be in-depth methodologies on centennial surveillance, mass MUAC screening, rapid nutrition assessment, and of course, inclusion of MUAC in MSNA. It will be presented later. And you will have also experience from Afghanistan, Niger. But after the webinar also, we are happy to share some experience from Ethiopia on multi-sectoral nutrition risk analysis. And Yemen also last year, they used their routine program data for forecasting the caseload for PIN. So there are a lot of experiences from different countries. So what we will be doing is we will be creating a repository within the Global Nutrition Cluster website, which will give you access to the different guidelines, country experiences, and the tools, and that way it will be much more easier for you to apply these methods in your country context. And of course, we remain available to provide you support, both from the Global IPC GSU, the GNC team, and of course, the Nutrition Information System Global Technical Working Group. So in summarizing, so the adaptation on need assessment and the need analysis is simply the new reality, and we will be putting much more effort so that it can be applied in your respective countries at scale. So I stop here, and we can proceed to the presentation from the IPC GSU. You can jump this one. Yeah. So we start with Damien or Thomas. And before that, if there is any question or comment, please post at the chat box. I can also take a couple of questions in the next 1-2 minutes.
Thanks, Anthony. Can you confirm that you can hear me?
Thomas, I can hear you, and I'm just giving opportunity for any comment or question. If anyone has, please post at the chat box. Okay, so there is no question. We can proceed to the alternative need assessment methods section. So Thomas, over to you.
And everyone, once again. So in this session here, following what Anthony has just concluded on, this session, we will start introducing those different alternative options that you can think of whenever you plan your assessments. If you don't have, you cannot conduct those standard surveys or assessments as the SMART surveys, which are the global standard methodologies or methodology for monitoring nutrition situation. So we will take you through based on the IPC acute malnutrition protocols, meaning what we will be saying here, it's mostly applicable to when you want to include a given area or your data into an IPC acute malnutrition analysis for your situation analysis, which then you can use it for your general needs overview and all the other purposes. Next slide, please. This slide, it's already been covered in the previous session. Of the different options that they might be available to you when you don't have the standard methodologies, the smart survey, for instance, or the rapid smart survey. So here, basically, you want to think in a way: if I don't have this, what should I think is the next alternative? And then if I don't have the next alternative, what should come next, and so on and so forth. If you don't have smart surveys, rapid smart surveys for any reason, then the next option that you can think of are sentinel sites. And here we refer to community-based sentinel sites, which will go in a little bit of detail in the following slides. And then in the absence of sentinel sites, which they are very linked to and already existing nutrition information system at country level, then you can think of exhaustive MIWAC screenings, right? Which also there are details on different parameters that you can consider applying depending on where and also the objective of your assessment. Then you have also targeted MIWAC screenings, and at the as a last resort, let's say for areas where access is limited for any reason, conflict, cyclone, etc. Obviously, depending also on the dynamics, population dynamics within the affected area, the IPC has a sort of guidelines on collecting data that can be used within the IPC umbrella as well to give an overview of the situation, obviously considering the limitations that will come along the process. Next slide, please. Sentinel sites and not necessarily health facility-based sentinel sites, right? And these community-based sentinel sites, they're usually purposely selected based on a given criteria agreed upon at the country level. Let's say, for instance, you are in a district A, and then the northern part of that district is cyclically affected by a given shock, and you want to continue monitoring the situation there, right? To make sure that you capture what's going on there, and then inform your decision making in a timely manner. And the situation in the northern part maybe it's not the same in the south or central. So you want to focus your attention in the northern, and then be able to track the evolution of acute malnutrition throughout the year. When we say that, when we say usually they are preset purposively and based on a preset criteria, that criteria or those criteria can vary from location to location, and that's what we meant here. So within the umbrella of the IPC protocols, the IPC only allows the use of community-based sentinel sites, right? And if you have many sites for a given area, that will be considered your unit of analysis, where you will be classifying into those different IPC acute malnutrition phases. The prevalence will be calculated by taking let's say the average of different locations of areas within that area, not necessarily by applying weights. Used for classification, although it might be taken into consideration to look into the upcoming season, how likely the situation would evolve based on the typical behavior that area has always been observing in the past for the same season. Data from sentinel sites, although this is alternative source, it must also be subject to strict data quality checks. And the data quality checks here are the same as those you are familiar with from the standard method, the SMART methodology, right? The plausibility check for both weight for height and Newark. Could also be considered as a sentinel site. This is just for highlighting. You may not have it officially something called sentinel site, but maybe you do your screening cyclically. Every year you do your screenings somewhere, and that could also be considered sentinels, can fall within the category of sentinel site data. This option here, either weight for height or Newark or both, depending on the feasibility. And as you also know, the IPC protocols do allow the use of either let's say indicator to classify a given area into the 5 IPC 𝗀𝗃𝗀𝗃 phases. And that is on the design stage of, and when you are already within the areas that have been selected purposively, let's say, we say that, the IPC protocol says that you should have at least 5 sites selected within that unit of analysis, your district A in this case. You should have at least 5 sites, and within those 5 sites, could you please go back to the, yes. Within those 5 sites, you should have at least 200 children with valid measurements. So children ages 6 to 59 months with valid measurements. That is applicable for non-pastoral area, but for pastoral area, given the dynamics as well, you still need to have at least five sites, but with a relatively limited number of observations of children that is acceptable. In this case, 100 observations with valid measurements, obviously. Next slide, please. We touched base in the previous slide was about the design, etc. And here, I just want to highlight and emphasize on the need to continue caring about the quality of the data, regardless of the fact that this is an alternative method. At the end of the day, you still want to take decisions based on that evidence, and to take decisions, you need reliable data. So you still need to care about the quality of the data itself, and you do that by training your measurers, right? Those you will be assigning to do the screenings in those selected sites. You need to train them, right? You need to submit them through the standardization test to ensure that they are well prepared to do the job. And then you still need to quality checks whenever the screenings are happening. Keep doing the daily quality checks to make sure that the data that is coming, it's coming in the right shape. And whenever some errors are committed along the process, you take action promptly and immediately to fix them, and then make sure that at the end of the day, at the end of your exercise, you have the right data to inform your plans. The second layer, right? After the
Thomas, can you Can you hear me? There is a question at the chat box. Maybe before you proceed to this one, can you attend to the question? There is a question from Geraldine.
Let's connect this.
Thomas, can you hear us? Thomas, can you hear us? We seem to have lost Thomas.
Hello, Anthony, can you hear me?
Yes, we lost you. Can you hear us? Can you be a little bit louder?
Okay. Thanks for that feedback. So
yeah,
you
I was
want me to
saying
take the question now?
Before you proceed to the screening, can you address, there was a question raised by Geraldine about the time period to collect the measurements at the chat box. Geraldine asked a question. Would you address that question before you proceed to the MOAC screening?
Yes, absolutely. You want to make sure that you collect data within a very short period of time, like we do also in surveys, right? Obviously, it depends on how the size of the area, right? But maybe in 1 week, less than a week, it is possible to. It could be possible. I mean, to start and finish your data collection, but you don't want to extend it to, let's say, a month, as said here. You want to make sure that it's collected within a very limited time period, right? To make sure that you capture the event of that specific time, a picture at that particular point in time. I hope that that is helpful. Okay, moving on to the screenings, which is a second layer in case the Sentinel sites are not available. Here there are two options. You can think of doing exhaustive screen. Let's say you have an area A, district A, county A, whatever the name the name is, and you can think of doing exhaustive screening for that area A or a targeted screening. And you will decide on which approach, obviously depending on your budget, as well as on the, let's say, the vulnerability within the area, let's say the spatial variation of the vulnerability within the area. If you are doing an immunization campaign, for instance, you could think of doing an exhaustive screening across the entire area, right? This has been the case in those times when country used to do the so-called child health days or child health weeks, and MUAC was usually integrated in this activity. And for the IPC, you want to make sure that that screening is happening within the same season of what you will be considering your current situation. So if you remember, the IPC always does a classification for things as we are at the moment we are speaking, the current, an overview of the situation as we are speaking, and then an overview of the situation or how likely the situation will evolve in the next 2, 3, 4, 5 months. So for the current, which has a starting point and then an end point, and you always link to a seasonality, acute malnutrition seasonality, your screening from, let's say, if you integrate it in an immunization campaign, etc., you have to make sure that it is collected within that same season and use in that season. And if you go for exhaustive screening, you should have at least 8% coverage of the number of children estimated for that, children 6 to 9 months estimated for that area. It should be you should cover at least 8%. Now, there might be also those situations where, going back to my previous example of the northern area is more, let's say, vulnerable than the south or central, and you want to capture the situation at that particular area, you may consider doing a targeted screening, I mean, and not necessarily going everywhere, right? But a targeted screening. And within the targeted screening, you could think of selecting your areas, so the sites where you will be doing your screening randomly or purposely. And once you have selected those areas randomly or purposely, then you have to make sure that if you do a random selection of the areas, inside the areas, you can think of applying either exhaustive screening within the selected site, community, for instance. We can consider, to standardize the language here, we can consider site as a community or a village. And within that village, which was selected randomly or purposely, you can think of doing an exhaustive screening if you have at least, let's say, 200 children aged, let's say, less than 5 months in this, 5 years in this case, from your population estimates, you could do an exhaustive screening. But if the number of children less than 5 years is beyond 200 children, then you would have to apply a random selection of children within that village. And it has to be door-to-door approach. You don't call children, at a given central point, and it has to be door-to-door approach. And you select at least 3 sites. Going back to my standardization here, the sites here being villages, you should select at least 3 villages within that district A, and then at the end of your exercise, you should have at least 600 children with valid measurements. And then at that point, you calculate your estimates, and then you use it in the IPC acute malnutrition. That is on the sampling process. But once you're already there, you have selected villages, you have selected children. How should you go about the actual measurement? Again, here we still care about quality, and we have to strive to make sure that we have the right data to inform our decisions. And because we are talking about MUAC here, we say that MUAC you should always collect child's age, right, to allow you to do your checks. And whenever, let's say, if you have more younger children, less than 2 years, over children 2 and above, then as recommended by the SMART methodology, you should adjust your prevalence by applying a factor which comes with the tool that was created by the SMART initiative. So if you don't have age, you wouldn't have control of this, and you wouldn't know if there is an likely overestimation of acute malnutrition. You have to collect sex. And your MUAC measurements, they should be recorded in numbers, not color-coded. In numbers, because you want to still apply the checks, the standard deviation, the disease preference scores, etc. And you also want to make sure that you collect edema, something that most of exercises do miss its edema, but you should still include edema in your screens. Next slide, please. Okay. This is a kind of an overview of the threshold that we use to check the quality of MIWAG data, especially when you're talking about the absolute values of MIWAG. So you can have a look at this table once you receive the file. But you have here for age, the age ratio, when is it considered excellent, acceptable, poor, problematic, sex ratio, and the digit preference score as well, and the standard deviation. Right. What you have between 0.1 and 3, it's exactly what you get when you conduct a smart survey, which comes with MIWAG. But the standard deviation, you also get it, right, by clicking on the results tab, not necessarily from the plausibility check, by clicking on the results tab, but then you don't necessarily have this rating. When is it excellent, acceptable, poor, problematic? So this table comes with this to help you. Next slide, please. Okay, I think this is where I pass on to my colleague from Afghanistan to show us the interesting experience on community-based sentinel sites. So one of the alternative approaches that I touch based in my session. Thank you.
Okay, thank you, Thomas. I do not see any additional questions except one from 𝗲𝗲𝗍𝗍. 𝗲𝗲𝗍𝗍, can you elaborate your question? I didn't get it. I don't know. Thomas, if you understand it, you can respond. If not, perhaps it's good to hear from 𝗲𝗲𝗍𝗍 himself. How do I unmute 𝗲𝗲𝗍𝗍𝗍?
I think 𝗲𝗲𝗍𝗍 is referring to the previous slide, advising that the ratio cutoff might not be reliable.
Okay.
And also we have a raised hand by Damien. But it will be interesting if you could unmute 𝗲𝗲𝗍𝗍𝗍 to elaborate a little bit more. Yes, yeah.
In the meantime, I just want to mention that in the Q&A section, not in the chat, we have also questions with answer also.
Yes, I did respond to those questions. Let me know if there are any new and unresponded questions. Is 𝗲𝗲𝗍𝗍𝗍 unmuted? If not,
Hi, Anthony. It's which 𝗲𝗲𝗍𝗍?
yes, please. Yeah, it's difficult to navigate.
I have two
through.
𝗲𝗲𝗍𝗍𝗍. I have two 𝗲𝗲𝗍𝗍.
𝗲𝗲𝗍𝗍𝗍.
Okay.
𝗲𝗲𝗍𝗍.
Okay, just a bit. Okay, he's unmuted.
Thank you, Isaac. Good morning, good afternoon, everyone. Thank you, Thomas, for your presentation. If you could go back to the previous slide. So these criteria are often used in smart methodology, and we have seen that this cutoff, which is the excellent, acceptable, poor, and problematic, deviate when you do MOAC screenings that are not a mass MOAC screening, because the sampling is quite different from what we usually do in a household survey. So it's just a bit of caution that I want to put here, that if you try to follow these cutoff points during your targeted MOAC screening, you might be shocked that it doesn't align to this sex and age ratio. So it's just a bit of caution. It's not even a question, but it's really good that we are able to see the standard deviation from the new paper has been included as a quality check. So just a bit of caution to put there. Thank you.
Thanks, 𝗫𝗏. Thomas, there are a couple of questions at the Q&A. I can read that for you. Do we use SD, I understand it's standard deviation, as quality indicator for MWAC? This is a question from Ali Nur. And Bassam has also the same question. So Thomas, can you respond to this one? Do we use SD as quality indicator for MWAC? By SD, I understand it is a standard deviation.
Yes, we do. And there's a paper that Hailu has just alluded to, which was published by Dr. Oleg, and it's also quite insightful on the MWAC quality checks. And yes, standard deviation is a test that you should be looking at for your absolute values. And that paper comes with 2 layers of quality checks. If you have age recorded in months, then you can calculate MWAC for HD scores and then apply your checks, and assuming the same standard deviation as weight for height. So the cutoffs, as in the weight for height plausibility check, but also if you are using absolute values, this is what it's being considered. So in short, yes, we do consider that. And I know you can also chip in.
Thank you, Thomas. There is another question also about, can screening be used to project the needs in 3-4 months? If not, as you may have indicated, does it imply that screening have to be conducted at every season in a year? So this is about seasonality and how frequently we can use the data, or whether or not the data collected will be applied for 3-4 months after the data has been collected. Thomas?
Thank you. I think there's a bit of, depending on the type of screening that we are referring to here, and especially the targeted one, which may not be coming from everywhere or most of locations within the District A, my District A in this case. It's important that you exercise a little bit of caution the way how you would interpret your findings, where you wouldn't generalize for the whole, let's say, district, and eventually you would limit to the areas where you did your screening, right? And remember, in my explanation, I was saying that the targeted screening, you are going for purposive selection because you believe there is a high vulnerability in the northern compared to this southern or the rest of your district. So you wouldn't generalize for the entire district. However, looking on the projection side of it, you could still project, right? For the up, I don't know how long have you said you could still project, because you will be also considering putting or factoring in different elements that influence or contribute to acute malnutrition beyond the acute malnutrition itself. And then you want to balance how likely malnutrition will evolve. And if you have historical trends, that will be even more, will give you more solid grounds to come up with your conclusions, other than if you just have one single data point from your screening in a given area. Over.
All right. Thank you so much, Thomas. Then I think with this we can proceed to Afghanistan experience.
Can I jump?
Azim?
Sorry.
Hello, Anthony.
Yes.
Damien has a raised hand.
Go ahead, please, Damien.
Yeah, thank you, Anthony. I just want to compliment Thomas and answer to another question also in the chat. For the question of projecting situation from MUAC information even less reliable than a survey or in an AMN process, in an IPC process, since you accept to classify the current situation, which whatever data sources you are using, if the data sources are complying to the quality and completeness check that the protocol is asking you, then you classify your current situation. From then, of course, you can do forecasting and projection. You can do it, yes. But then according to what's the first source of information to your outcome, in this case, acute malnutrition, you have been using, depending if it's screenings, sentinel sites, smart surveys, or whatever, you would have evidence level difference. It can be high, it can be medium, it can be acceptable. So this is where you reflect that the first outcome you have been using to classify the current can be more or less of quality, let's say. This is one. And another, there is two questions in the chat coming around the standard and the alternative methods. I think the overall approach, as I answer in the chat, is for us as we must be nutrition information system specialists, we must be nutrition data specialist, IM, whatever, but we are dealing with nutrition data and we want to describe what the situation to better target. So of course, we don't want to compromise our standard according to the financial situation, let's say with donors and all the constraints we are facing since the beginning of 2025. So the standard are still smart surveys, mixed DHS, but it's also good to have a holistic approach, to know that we have a hierarchy and we have the best solution, but if we cannot apply the best solution, then it is not we are stuck. We have alternative solution and we have this hierarchy, and at the end of the day, what we want to avoid is to say, we cannot say anything. We have a hotspot last year, but this year, due to no money, we cannot say what is happening there. We want to at least can say, okay, it is less reliable. However, we think the situation this year or for next year is this. So this is the overall philosophy of this webinar. Over. Thank you.
Thank you, Damien. Now over to Afghanistan. Azimi, please.
Again, thank you so much, Anthony and Thomas. It's Azimi, Nutrition Information Management Specialist from Afghanistan Country Office, UNICEF. On behalf of team and cluster colleagues, 𝗶𝗃 is around. I'm going to present Afghanistan experience on nutrition community sentinel sites. Can go to the next slide, please. Overall, just I want to share briefly about overall situation. As you may know, Afghanistan is one of the biggest UNICEF program and biggest nutrition emergencies. And during the last 5 consecutive years, the total number of wasted children, estimated wasted children, almost is the same, around 3 million wasted children in the country. It shows that the situation is not improved and has the same problem. In 2050, however, there is a 3.5 million estimated children acutely malnourished and around 1 million pregnant and lactating women wasted. And also in 2015, the number of mom cases compared to 2024, 28% increased. On the other hand, in the chronic malnutrition. You can see out of 34 provinces in the country, more than around 11 of them, they have more than 40% stunting rate, which is around overall 3 million children stunting in this country, the country with 46 million population. And also the map, I am not going to go by detail. You can see the IPC3, which is orange, and IPC4. For the last IPC acute malnutrition, you can see more than 70% of the provinces are in IPC3+. Next slide, please. Yeah, okay. Let me share you some background information. The last National Nutrition Smart Survey, which was happened, it was 2022. However, in 2023 and 2024, UNICEF secured the fund for conducting the National Smart Survey. But as you may know, or not, the de facto authority, they are mainly banning household visits, which is also included not only for the polio campaign, but also for the household survey. And we couldn't successfully conduct a smart survey by having the money. Unfortunately, it was not possible. But in 2024, the nutrition cluster was exploring about an alternative method for estimating pain and informing IPC in consultation of GNC and IPC GSU. So during that time, there was 21 provinces with a community nutrition sentinel site, which is supported technically and financially by UNICEF. And they are also used for 13 provinces, mass MUAC for HNO-HRP and IPC analysis. Now, next slide, please. I'm going to, next slide. It was a brief background. I'm going to present the overall situation in 2017. In 2017, in Afghanistan Nutrition Information System, there was no national nutrition smart survey conducted till that time. Only there was 2 data sources for nutrition, reliable data sources. One of them, IMAM reporting or CMAM reporting, which was a comprehensive reporting system. And also, there DHIS2, there are some proxy indicator nutrition related indicator in the system. There was no field monitoring system, no surveillance, and no national smart survey conducted on that time, but some other localized survey. And there was no mechanism for supply chain management. You can see in this scheme. As I mentioned, why Afghanistan, UNICEF, and cluster decided to start piloting the community sentinel sites. Anthony, sorry, could you remind me about my time so I can adjust my presentation based on the time I allocated for me? Sorry, Alex, I want to be on time. Okay, now, protracted nutrition crisis in need continuous data points. Definitely that you saw during the last 5 years, there is no difference in the overall situation. However, there are several intervention is happening in the sensitive and specific nutrition intervention. There was no proper mechanism to regularly monitor nutrition situation. Heavily relying on a nutrition survey or a smart often is expensive, heavy machinery to move. In addition, the seasonality is very important. During 2022, it took almost more than 4 months to complete data collection from all over the country because of lack of shortage of local capacity for data collection and data management. So this is one of the main problem. Definitely, we can say that this is a gold standard, but are we able to collect the data in the peak season in the same time everywhere to at least monitor the nutritional situation? If yes, that's good. Otherwise, it's very difficult to use those data to interpret the context and the situation, what's going on. Limitation in the capturing the seasonality, I mentioned it. Also, I mentioned the access and political barrier. The fact you are very reluctant for house-to-house visit. Recently, also there are some the blocking the counseling session, house-to-house counseling session. In addition, and also the funding challenges. Now we all have that problem and lack of population-based data management tool in the country. So these were the main reason that we start piloting the community nutrition sentinel sites in 5 provinces. Next slide, please. Okay, I will try to be very short because this guiding principle, I think one of the most important points that contributed hugely in the successful implementation of quality nutrition sentinel site. When we were designing the system, we consider managing the complexity, different partner, different agencies, de facto authority, implementing partner, CHW, community health worker. I will explain about that. The people that are collecting the data, and also the data user cluster, UN agencies. So how to bring all these people together, understand their needs, involve them in the planning stage to buy the system, to own the system, and to feel they are part of the system. So it is one of the most important things. So we need to consider this is a journey of thousand steps. It's not simple as developing a checklist or preparing some training material and collecting some data, but it's mainly to advocate on credibility of this data from the beginning by involving all partners. During the drive the adoption is mainly about, you can believe that for 5 provinces, it took almost more than a year, and we revised 4 times, modified the approach methodology 4 times with consultation of the CHW, provincial team, and all other partners, aim working group, cluster team. So it took a lot of time, but to be consistent, to show very rigid or clear result, tangible result that convinced partner to contribute, and in the next stage to utilize data. They are the most important soft skills that mostly they are ignored in the system development part. Definitely, as I mentioned, this is one of the toughest priority for the UNICEF, not only UNICEF, for the cluster. 3 million children wasted. So for this big emergency, we need a regular monitoring tool to provide information in regular basis at sub-national level. So that's why this system, or this design of this system took place. Commit to progress. Consistency was one of the another key factor for successful implementation. I mentioned about the leading with the vision. Establishing a shared vision with all partners, with the partner with different mandate, with different priorities. This is really tough, hurting job, but it took lots of time to bring everyone together, and I should thank really our cluster team to great support for this initiative. So this is another important point, to focus on building a shared vision from the beginning of design of any system, which is not limited for our surveillance. Definitely risk and preparation. I mentioned we are in the country with de facto authority, very reluctant. The collaboration, there was lots of issue, but what we did with all our partner, with the implementing partner and the field team, we listed all of the potential bottlenecks coming through the local government, and provide or prepared in advance a strategy to tackle such kind of problem. Communicate clearly. I think I mentioned this one. Guarantee experience is something that from the beginning, from the 5 provinces we conducted, when we presented the result for all partners, the objective, everything was clear. So that's why all of the partners were very interested to invest their time, their effort, and their expertise to this surveillance system to be successful. And select the first project carefully. That's why it took 1 year to have something solid, grounded, after be convinced or confident about the system which is worked smoothly and with a good quality, then expanding the system. Okay, the next slide, please. Okay, Afghanistan's community sentinel site is very simple. Is a MUAC plus ODEMA, definitely age and sex is also part of it. And this is a questionnaire, and this is a community health worker. They are doing the house-to-house visit and doing the MUAC measurement as actual work. Okay, but maybe there is a question. I want to explain that one. Becca, my colleague, is also here at the end. Maybe he also, if there is a question about utilization, he also jump in and commented. In Afghanistan, we conduct a research or a study. More than 100 local smart service data was collected, and based on that data, it was found that almost 35% of all wasting children in the found only and exclusively by weight for height, and 45% of severely acutely malnourished children exclusively defined or find by weight for height Z-score. So for the utilization, this factor was applied in the finding from prevalence finding from the community nutrition sentinel sites. Okay, next slide, please. Okay, I want to explain you the processes. Overall, the health posts are the sentinel site in Afghanistan. Health post is a health community-based health establishment that is run by a community health worker, which is a volunteer health worker. The catchment of this population is 100 to 200 households, which is 1,000 to 1,500 to 1,000 to 2,000 population. So the starting point was to select select the community health worker and the health post. In Afghanistan overall there is 20,000 health posts. So the selection done based on some criteria that I don't want to explain. If you want, I definitely share the guideline. Then we used a smart methodology training material, modified version for training the CHW. Then we did the field testing, and after the field testing, a standardization test based on a smart methodology was applied. In case there was some issue with the CHW or the quality of the collected data, retraining of the CHW. In some cases that we found it's impossible to work with this kind of, with some of the CHW, the site was replaced with a new CHW. And then there are some more updates. We previously it was a systematically random sampling selection of a household at the community by CHW, but we found that it is some error in problem bias in the collection of the household. Therefore, we introduced household listing. So the CHW lists all of the household in their catchment, and in the national or subnational level, the random sampling done to sample 40 children per sentinel site. 40 children per sentinel site. Then data collection is done, data compilation, plausibility check. Mainly we use a smart methodology, and I will explain you. We use the global IPC quality assurance unit tool, which is Moana. I will explain it later. Then validation after the quality check, if the quality was assured based on the criteria that Thomas mentioned, the AIM working group and cluster the data is presented in the with cluster and validated. And the final step is the quarterly bulletin is developed. Just one thing I think I missed, the data collection is in the 4 time period in a year, beginning of the spring, January, April, July, and October. In this month, data collection and duration of the data collection is around, for actual data collection is 2 to 3 days, but overall for completing from 34 provinces, it took maximum 20 days, which is very short period of time. So one of the great experience from this community is collecting this data from huge number of, next slide please, from big number of site is amazing. So I don't want to explain this one. I really should thank FAO IPC Quality Assurance Global Team for their great support, in particular Thomas, that support us to improve quality of the surveillance. And this is the quality assurance tool, which is in the R software application. We use this one for doing quality assurance. Next slide, please. Okay. This one is our overall in Afghanistan. Fortunately, in January 2025, we succeeded to reach to all 34 provinces in all 41 districts of the country. There are 442 active sentinel sites reported for January. The number of cohort, the cohort is 19,000, which is very close to National Smart Survey, which is 22,000 something. So the scale or volume of the sample is also tangible. And this is the not only, as I mentioned, it's not only one time data collection per year, 4 point of data collection per year, which help us not only to monitor the nutrition situation in one point of time, but we can compare between different time period in the same time period in different years for different provinces. That's one of the beauty of this Sentinel site, which is efficient. And I should mention it, emphasize, it's an efficient way for data collection. Just as a very example, 12 round of data collection, which is 3 years, is the cost is equal or less than one time smart survey data collection. Next slide, please. Okay, results so far. I will be fast on that one. Okay, so each quarter after the completing the process, we are publishing the nutrition bulletin with partner, which is a very well received or very well appreciated by the all, acknowledged with all partners, including donor communities. Next slide, please. Okay, this is one of the important, the result too, and for multi-sectoral nutrition analysis and humanitarian response planning and coordination. We used this data for Afghanistan humanitarian need overview and response planning for 2025. In addition, this data was informed the IPC food security and IPC acute malnutrition in the absence of the smart survey household data. By integrating community-based seminars into the nutrition cluster coordination mechanism, response to malnutrition crisis is more proactive, targeted, and efficient. As one of the examples I can share with you, however, we cannot represent the result of this community sentinel site to a specific geographic area, but in some extent, we found in some sentinel site the wasting level or wasting prevalence is very high. So it triggered deploying the emergency mobile team to respond to the situation. And really we found that in some area, in some site, there is no social services, no health, no education. And so this data also supports cluster team to actively, proactively do response to emergency, which is impossible to respond if this kind of tool was existed. Okay, and you can see the nutrition cluster coordination cycle. The third one, as I mentioned, okay, this is fine. Regular nutrition situation monitoring at subnational level. So you can see this bar. It's one blue, one is orange. This is exactly the January 2024 and January 2025 for this promise that we have data. So this kind of information, I believe, we can interpret the situation, what's going on, and we can somehow decide what's going on. When we are talking about the surveillance, it's very clear that we cannot represent it. But one key aspect that almost in most of the household survey we are missing to monitor the nutrition situation at the community level, which this surveillance, by comparing the same methodology, the same location and same timeline, we can understand what's going on in, at the specific geographical area. And the last, I believe, the last slide, please. Yes, making a smarter nutrition surveillance. So we are not going to be limited for the current achievement. Our next step is definitely first of and most important is more working on the quality. However, the quality is Thomas can confirm that it's improving a lot, and but we are going to use real-time data collection. Real-time data collection using mobile technology for in 2025. We are going to use the Moana and a smart plausibility check integrated as part of nutrition information system and as part of the community nutrition surveillance module. So this is something that help also subnational level, first building their capacity, secondly providing this in this environment to do the quality check, to use the system automatically providing this quality check and respond properly in the weak areas. Okay, we are going to embed this dashboard of the community surveillance sentinel site into the enterprise content management of UNICEF, so everyone could access that one. And this platform, the community surveillance platform, we plan to conduct national nutrition survey and early child development survey. Unfortunately, due to funding constraint, we are going to, if possible, utilize this platform to collect data only at the national level to understand at least what's going on at the national level. And definitely, we have a deep dive analysis and cluster. We are going to include this one to answer somehow what's happening and triangulate this data with routine monitoring and supply data as well. Okay, this is all from my side. Thank you so much, colleagues, for your time. I am sure Thomas and Becca are also available in case you have any question. Thank you so much.
Thank you, Azimi, and also the rest of Afghanistan team, Becca and Koki, who couldn't join today. Excellent, very rich presentation. It's worth the time you have taken, and we encourage everyone to reach out to you as somebody with experience who can share your best experience to country. So given the interest of time, we will have to move to the next experience from Niger. I hope it will be very brief. Then we take some time for Q&A and then followed by MSNA MUAC piloting. So thank you, Azimi. Thank you, Becca.
Thank you.
Also thank you, Koki. So we proceed to Niger. And we come back for Q&A once we are done with Niger. Thank you. Over to Niger team, please.
Hello, everyone. Thank you, Akene. In Niger, we haven't been really able to carry out a national smart survey since 2022, as in many other countries in the sub-region. Also, we have been facing a lot of difficulties to have up-to-date data for PIN calculation and advocacy. As such, in 2024, we coupled a national acute malnutrition screening with the National Vaccination Day and the National Micronutrient Day campaigns. Next slide, please. This screening this was a national screening carried out through the 72 health districts in Niger. This screening took place from the 28th of September to the 1st of October 2024, using an exhaustive door-to-door sampling approach, and children aged 6 to 59 months were screened for acute malnutrition. Since the screening was coupled with vitamin A supplementation, deworming, and vaccination, an additional 1 surveyor was added to the existing team. As such, for screening, we had 2 people responsible for screening, an investigator and a measurer. We used ODK for data collection, and results were sent on daily basis, and data was to the server, and data was analyzed using ENA and SPSS. Regarding quality, data quality, the standard deviation less than 15 was used for data quality check. As such, only 47.2% of the health districts were eligible for the IPC analysis that we plan to carry out using this data. Slide. The advantage of this method is that we were able to have data at district level. Also, since this screening was coupled with another activities, that is the vaccination and the micronutrient day campaigns, resources were mobilized and put together. Another advantage also is the short term of the availability of the report. And also this data helped us to conduct both IPC, AMN, and FoodSec on time. The total cost of the screening activities was estimated at more than 500,000 USD, but due to lack of funding, the methodology had to be revised, and after prioritization, the cost ended up being around 310,000 USD, which was less than our previous SMART survey. On the disadvantages, the fact that we use different collection tools, like for this screening, we used ODK and other collection tools for vitamin A and vaccination, it greatly affected also the quality of the data. And given also that Niger is not widely covered by internet, some health districts found it very difficult to upload data into the server at the end of the day. Due to insufficient budget also, the number of supervisors, as I said, the methodology was revised to suit the budget. So the number of supervisors were reduced, and this affected also the quality of the survey. I think this is all for Niger. Thank you, Atene.
Thank you, Gali. Thank you so much.
I tried to be very short.
Yeah, very important content though. Thank you so much. We take 1 or 2 minutes for Q&A. I hope most questions have been responded to, but if anyone has any additional question, would be good to address those questions. But so far, I do not see any question at the Q&A and at the chat box. But if anyone has any question, we take 1 minute. There were questions regarding the data quality, whether or not this data will be accessible for evaluating its standard. I think that was a question raised by 𝗲𝗲, of course, smart initiative. Yeah, I think it would be good to liaise with the Afghanistan team and of course with Niger, and we happily can share this data and see if there are any lessons that we can learn in progressively improving the quality of data. So I hope that's possible, and we can coordinate this knowledge sharing between partners. Okay, 𝗲𝗲 raised your hand. I hope it is a new one. So 𝗲𝗲, over to you, please.
Thank you. You have addressed my question on regarding the Afghanistan, but on Niger, this is very interesting to see that it was systematically applied in a campaign, which makes it more efficient. So I'm very excited to see that, and probably the same thing applies to Niger also. Our as part of the global team, our main input to the global nutrition team is to make sure that all these data are up to par, which I believe it is, and we just want to make sure that we are also providing you support in checking all those top quality parameters. I can see that most of you are using the standard smart quality check parameters, which are the plausibility check. So it's just to say that we are there to see if and when you need these quality parameter checks. Thank you.
Thank you, 𝗲𝗲, for that point. Yes, when it comes to any sort of need analysis, need assessment, credibility, transparency, these are important aspects need to be addressed. So the quality assurance and being transparent about the quality of your data is one important aspect, because at the end of the day, the decision makers should be confident in utilizing your data, and whether it is for resource allocation, for any strategic and operational purposes, it has to be quality assured by all possible expert groups, so which includes the SMART initiative, of course, NIS, GTWG. We are happy to facilitate that, and I need to mention that we are still in the learning process of introducing these alternative methods. Again, we can have a dedicated discussion on how we can improve the quality and transparency aspect of the alternative data collection and analysis method. So important point. Thanks. Damien, quickly, please.
Yep. Thank you. I'm just trying to relay some question from the Q&A. And this is maybe a way forward for Afghanistan and Niger. First of all, thanks. It is very interesting work you're presenting here. I think you have both two different cases. One is sentinel sites for Afghanistan, and one is mass MUAC screenings. And you both have recent national smart surveys happened. So would you be able to, it would be interesting to have a kind of cost comparison of both approach to see in numbers actually what's the difference in terms of cost, because it is not, you probably have all the element to do, maybe for looking forward for later, not right now, but it should be interesting to have this point also. Over.
Thanks, Damien. I mean, this falls under documenting the lessons and looking at the various aspects of application of the alternative data sources, whether it is the cost efficiency. We do argue that it is cost efficient, it is less complex, and all good attributes of it. However, that has to be systematically documented and shared I hope that's the next phase of the things that we will be doing. So during the 2025, it will be a matter of making sure that there is a sufficient knowledge sharing. Earlier, a colleague mentioned there are also other country experiences. For example, in Somalia, there was some experience. Elsewhere also, we understand there are experiences here and there. But this year, we will be documenting those experiences. And of course, from that, various questions could be raised with regard to the cost, technical feasibility, national authorities' ownership, sustainability. A number of questions could be raised. I think this needs to be addressed progressively, but we have to acknowledge that we are at initial learning phase, but we have opportunity to apply these methods this year, given the circumstances that we know relating to the significant funding shortfall. But again, I would like to emphasize that this information will continuously be compiled and shared by GNC to all of you, and I hope it will be a platform for learning from each other. So with that, we now move to the last segment, which is MWAC piloting. MWAC in MSNA piloting is another approach. And I hand it over to Martin from Reach Impact Initiative. Martin, over to you.
Thank you. Thank you very much, Anthony.
Your screen has not been shared. Isaac, can you put the screen? Can you share the screen? I cannot see it.
The screen is there, Anthony. I think probably internet on your side.
Because I can see the screen, Anthony. On my side, I can see the screen.
Something wrong. Okay, over to you, please. Go ahead.
Okay. I was just saying thank you to Anthony for organizing this really interesting webinar on alternative data sources, and also to my previous colleagues who presented on the IPC and the lessons learned from Afghanistan and Niger. Which is quite interesting. So I think for us at Impact Reach, I just wanted to take you through methodological notes that we've been working the last 1 year with the NIS Global Technical Working Group, GNC-IPC, a few also global experts, since we are seeing with these interesting times, we're trying to leverage all opportunities we can have for nutrition data. So my presentation is quite brief. It's not very detailed in terms of going into the aspects, but just to give you a quick overview of the pilot that we are hoping to plan to do for this year, and also just to learn a bit more about what are MSNAs. Maybe these are some of the questions some of you have come across our research products out there. So maybe next slide to start us off, to just highlight who we are. So I think we've heard a bit about impact initiatives, reach initiatives. I think at the country levels, we are very cognizant of the reach initiative, which is our primary initiative mostly on data collection, primary data collection, using different approaches. We also have other initiatives, but Impact oversees all these initiatives, and we are based in Geneva, and we are among the largest independent data providers in context of crisis. And this is some of the countries that we are operating globally. And I think all of us, we are also being affected in terms of these unprecedented times with the humanitarian crisis that we are facing right now. But this is just a bit of a background in terms of who we are. So when you see Impact Reach, we are actually the same organization. Sometimes we work through ACTED in areas that we are not operational. So we work as a team in terms of mostly our main focus is on data collection and primary data analysis. Next slide, please. So maybe just to quickly start us off, because I've been also engaging online and seeing a lot of very interesting questions. Maybe I think if you're keen enough at the beginning, I think Anthony mentioned what MSNAs are, but just to jog your brain, maybe on the chat box, you can try and explain what is this acronym, does it stand for, like what is an MSNA? And the second question is on the GF. I think if you've been in the humanitarian sector, you've definitely come across this acronym. So maybe I'll give you a minute to try on the chat box and just maybe highlight what you think, what is an MSNA and what is a GF. I'll try and request the rich colleagues who are in the call not to provide answers, because at least for them they do know, but just for the wider audience, what do you think an MSNA, what does the acronym stand for, and what is a GF? Maybe a minute or so. Or these are completely new acronyms you've never come across. That's also another option, that you've never seen this before. So no volunteers who are bold enough. You might also get it wrong, you might get it right. I think that's the essence of learning. But I just wanted to jog your brains a bit in terms of what MSNAs are and GFs is. So maybe if you think for a few more seconds, if anyone wants to volunteer. So I guess silence means maybe some of us, we haven't come across MSNAs before.
Martin, there are a lot of responses at the chat box, so people are writing at the chat box.
Okay.
So clearly there is a good level of knowledge of these terminologies. And I guess we can proceed to the next slide.
Okay, so for the next slide, just to give you a quick background of what MSNAs are. These are quantitative household level needs assessments. So MSNAs are multi-sector needs assessments that we do in terms of trying to capture the magnitude or severity of the needs in different population groups, in different contexts as well. And this mostly started around 2016 after the Grand Bargain agreements, in terms of how can we also effectively provide information that is independent and also is crisis-wide, and also making sure that the process is also systematic enough that we can be able to replicate our methods in various countries. And just recently, I think for the Nutrition Working Group, we were able to implement the mortality module in 3 countries last year. Since 2023, we've been trying to incorporate a bit more of new indicators as well within the MSNAs. And I think for 2025, based on the ongoing humanitarian crisis in terms of funding, we have around 7 to 10 MSNAs. But this is just a graph just showing you some of the countries that we implement the MSNAs since 2016. And this just highlights some of the MSNAs that we conduct as Impact Reach. I think some of you have come across other MSNAs that are also implemented by other agencies like IOM or UNHCR, but these are just a bit for the MSNA that we implement as Impact Reach. Next slide, please. So also just to give you a quick overview in terms of how we design the MSNA, I think most of you also have come across other research products out there, like humanitarian situation monitoring, some qualitative products, some GIS mapping products. But for the MSNA, which is the primary focus for this presentation, it's usually an annual research cycle that we just do one MSNA per country, because it's quite big and it's quite intensive in terms of the many other sectors that we also coordinate with to make sure our indicators are also in line based on the the sector kind of guidance that provide this. So in terms of the timeline, most of the time when we have feedback and technical discussions at the research and design stage is usually at the first quarter of the year. So that now from the second quarter, we're able now to start the data collection, and towards the end of the year, when we also have other IPC analysis, we're able to provide and feed into the IPC analysis, and towards the end of the year from November, that's when now we start publishing our results. So because it's such an intense activity that really collects various indicators from different sectors. I just highlighted a few. And also for the GF, for the ones who haven't heard about the GF, it's the Joint Intersectoral Needs Analysis Framework, because the MSNAs tries to bring all these indicators. As much as we are nutritionists, we understand the severity from a nutrition point of view. We also try to hear from the other kind of sectors, from food security, from the health cluster, from the shelter cluster, from IPC, from GNC, what type of information is needed, and we can be able now to systematically consolidate this within the MSNA. So this is what ideally an MSNA looks like, and the sample sizes usually range from around 20,000, and I think I saw some comments in terms of how maybe other alternative methods like DHS and mix, which usually have a huge scope like that, could also be leveraged in terms of nutrition data. So this is where the discussions have been started from last year in terms of, for nutrition, what can we do in terms of the MSNAs. Next slide, please. So also in terms of how the MSNA tries to fit into the prioritization, I think by now everyone understands what prioritization is, and the planning in terms of with limited resources, how do you prioritize which sector, which country, which region in terms of severity. And this is where the MSNA comes in, and it feeds into the GF. It also feeds into the IPC. It also feeds into the various products that you always see, which are open source. We also have a repository that we publish all the TORs or the final reports, even the data sets. You can go to the resource center and you can still be able to see all our research products that we do. That it also includes countries that we do, even the classical nutrition surveys like SMART surveys as well. So we are able to in a very transparent manner, be able to provide this. So this is how the MSNAs kind of feed into the prioritization and planning, and this is also why we've been trying to leverage an opportunity for piloting the MOAC in MSNAs. So next slide, please. So I think the next two slides is just now to give you a bit in terms of what we are currently collecting in the MSNAs, and what we are also now hoping to plan to collect within the pilot. So the current indicators, as I said, they're multi-sectoral. They have various themes. So we have mandatory indicators that all the MSNAs in all the countries that we collect have to be there. And also we also have context-specific indicators that depend on the context, depend on what the National Nutrition Cluster is highlighting as a gap in terms of some of the indicators, and mostly our main partner is usually the National Nutrition Clusters, the GNC-IPC, AMN as well, to feed into this process. So currently we have been collecting systematically over the last couple of years IYCF in emergencies indicators and child morbidities indicators, mostly as mandatory. And then you have the full IYCF module as context specific. So this is based on demand for some of the clusters that don't really have any data. And this has happened a couple of times in the past, where they see there's an opportunity, maybe we could be able to incorporate a few more extra context specific indicators, or more like contributing factors rather than the outcome indicators. But at the end of the day, there's always that also push. Yes, we have the contributing factors from the MSNA. What about any outcome indicators for areas that, or for context that we absolutely have no data or no information for this? So this is just what we are currently doing. So the next slide now just highlights the methodological note that has been in the background for the last 1 year, and we have been really consulting with the GNC GNC-IPC, the Nutrition Information Technical Working Groups, OCHA, a few other experts globally, just to make sure the work module pilot can be able to provide robust enough data that can also be used to kind of provide some level of understanding in terms of severity, which is very context specific for areas that we absolutely have no data or hard to reach context. And this is where the whole discussion has been. So the final version now, we have been able to submit it to the NIS group last month. And I think there will still be a few more learning curves by the time we are doing the pilot process, maybe in 1 or 2 countries, and we'll come back with a webinar maybe towards the end of the year, and we'll be able to share what we found in terms of the pilot and see how the data looks like. And this is how we have been also being transparent in terms of just highlighting this is a pilot for now, and then we'll be able to see how the results look like. So in terms of the guidance notes, so this slide just summarizes almost around 20 pages of the guidance note, which provides more technical details in terms of, is it a full coverage MSNA? So MSNA, if you're doing a national survey, you ask yourself, do you want to collect MUAC data in all the areas, or do you want to do a partial MSNA in terms of partial coverage? Only collect MUAC in some of the areas that maybe has been flagged by the National Nutrition Cluster to have gaps that are highlighting that we absolutely have no data, and it will be good if we can be able to have some MUAC or some nutrition outcome data as well with the contributing factors that we do. So the guidance note that just wanted to highlight here also gives a bit of a difference in terms of how does it vary with the other classical nutrition methodologies in terms of the sample size, in terms of the training, in terms of the data analysis. So these are the technical details that you can find in the guidance note. But for this, I just wanted to highlight a few differences in terms of the variations. The first thing is for the MSNAs, because we capture various population groups, we are able to disaggregate in terms of the population groups like the returnees, IDPs, host population. That's always one of the main asks within an MSNA. We also use the matrix frame sampling and application of survey weights because it's a huge national level kind of an assessment. If we are able to aggregate or aggregate data at any admin 1 level, you can be able to look at survey weights. But if you're now doing the partial MSNA, we are just focusing on one region. So that should be indicative in terms of that specific region. The third thing is it's supposed to minimally inform the IPC classification, but not really pin caseload estimations, because in terms of the reliability, it's not robust enough in terms of the sample sizes, because if you're collecting 20,000 households, if you consider collecting children, that would be like so many children that you might not be able to really collect within such a short period of time. And also we also have many other indicators that you actually collect, and you don't want to compromise in data quality. So in terms of the precision, we always say it's an R1 in terms it's a good enough evidence to understand severity, but we provide a caveat, maybe not to be extrapolated for the pin caseload estimations. And then for the analysis, I also saw this in Afghanistan. We also use the R scripts, but the whole data quality check, as Hailo has mentioned, we also base it on the smart survey plausibility check in terms of the standard deviation, in terms of all these other flagging criteria that you have in terms of digit preference and all this, but they are within the R scripts that we are also able to be able to share publicly. So my last slide on this is just giving an example. Maybe next slide, please. In terms of how the pilot might be adaptable for our country teams. So the left side, this is what our normal structure in terms of teams at the country level that are focusing on the MSNA without any nutrition component look like. And in terms of the nutrition component, because for nutrition, you're looking at a smaller age group, you're looking at children under 5 and maybe potentially specific women pregnant or lactating or women of reproductive age. We would propose to have an additional team that exclusively focuses on the MUAC measurements to ensure you have data quality. and you also invite the National Nutrition Cluster within that country also to help with the training. It's an additional one-day training that you can also try to do the plausibility, the standardization test as well. And for the countries that we have nutrition assessment officers, this will be the main checks in terms of ensuring you have those daily data quality checks. And for countries who don't have a full-time nutritionist, that's where I come in to provide this background support to make sure we have this data quality checks every day before the data collection period ends. So this is just a very brief kind of summary that I would have wanted to go into too much details, but for now, because of the time, I just wanted to give you a very brief presentation in terms of the pilot. And the idea is, after we've done the pilot in 1 or 2 countries, hopefully this year, with all this uncertainty, then we'll be able to organize with GNC in terms of maybe having a webinar where we provide more information, more in-depth information in terms of what does it look like, how does the data look like, and hopefully then we see in the future how this can also be scaled up in other countries as well. So I think with that, I'll stop at that and maybe hand it over back to Anthony, and I'm also happy to have any questions from the audience. Over.
Thank you so much, Martin. Again, a very good initiative in which we all are collaborating. It is at the initial stage, but there is a very detailed guidance which is right now undergoing a technical review by the Global Nutrition Information System, or technical working group. Thank you for sharing this new alternative, and I hope we will be able to pilot it in some countries and, of course, scale it at a larger scale. So thank you so much. We ran out of time. Of course, it was initially scheduled for 2.5 hours. I think we can finish earlier, but since several people have left, I just moved directly to the last concluding part. It's just to give you a summary. We just talked about why it is essential at this point in time to really consider alternative data sources and analysis methodologies. I think no one really disagrees with that, given that we are now in the middle of significant funding shortfall. So the situation dictates that we apply these methods wherever it is possible. As you have learned, there are different levels of complexity even with these methodologies, and also we shouldn't be compromising the quality of these alternative methodologies. But in general, it allows for more flexibility and creativity in terms of adopting various methodologies. So as a next step, there are 3 things which we will be doing. One, there is, as I mentioned earlier at the beginning, there is an adaptation guideline which talks about the recommended methodologies and the tools and processes for conducting need assessment and analysis in resource and access constraint settings. So that guideline is almost done. It should be available for every one of you in the next couple of days, hopefully by early next week. That's one. And secondly, GNC will be creating a repository in our website dedicated for these alternative data sources, where you will have all the available tools, guidances, recommended best practices, country experiences at that repository, and that way it would be useful. We also hope to create, if possible, an e-learning module on this one, but we will confirm during the course of next couple of months or so. So there will be some platform for sharing experience and learning and accessing some guidance on this one. Thirdly, as you know, at the end of first quarter, beginning of second quarter, every year we compile assessment plan. So this year also we do the same exercise. I will be reaching out to you with this template. This is an example from one of the countries, specifically South Sudan, for the last year. So that in the template, there is really nothing new here. It's just populating the table with the assessment you will be conducting, whether it is planned or is upcoming and so on. You could add as much detail as possible. So I will be sharing this template to all country clusters and sector coordination mechanisms. So those are the next steps, and we remain available, whether it is the GNC coordination team, IPC, GSU, you work closely with them. And of course, we have now Reach Impact collaborating with us. And of course, NIS, GTWG, and colleagues who are actively leading that mechanism, SMART initiative, the UNICEF and WFP, everyone will be available to provide you the usual support. So those are the next steps. Before we finish, I really want to thank all the presenters who collaborated together with the GNC team in making this possible. We do hope this is useful, and I hope you start also applying these methods in your countries. And also for the participants, thank you for your patience and for your active participation. And with that, we end this webinar. And I thank you so much and have the good rest of the day. Thank you so much.
Thank you, everyone. Have a good day.